Hello, I'm Dr. Marwan Abourass. In a recent dialogue with a dental student, graduated 2018, I inquired about the number of endodontic molars he did, or he managed to complete. 14, he said. Then I asked the question, what type of root canal sealer did you use? He hesitated, and then he said, I didn't use any sealer because we are not authorized to do. Instead, we just extirpate the pulp and temporize with a cotton pellet and IRM or cavet, and earmark the patient file for a specialist or an endodontist. This interim procedure, this practice, is very frequent, perhaps throughout the world. But where? In commercial run centers, in hospitals. Another alarming incident that I'd like to bring to you is a United States specialist, endodontist, who did the root canal and temporized with a sponge and glass ionomer cement. Good job, endodontically speaking. However, look what happened. The patient went back to the referring dentist, and the dentist did a crown on top of the temporary arrangement. The temporary arrangement, the glass ionomer cement, was short. So was the crown. There was an open margin on the distal. Exactly. The same problem was the temporary, was the final restoration. Both practices are inferior to me. Both practices are unacceptable, worse practices, because they neglected the issue of coronal microleakage. I'm very surprised from the endodontist who basically forgot the Marshall and Maslow research in 1961, Swanson and Madison in 87, Magura in 1991, Saunders and Saunders in 91 and 94, Nennard and Gutman in 96, Elvis in 98, Helling in 2002. All of these research strongly indicated that temporary materials on completed root canal, materials such like ZOE, IRM, cavet, are not acceptable. They do not prevent coronal microleakage. Once such microleakage penetrates into the pulp chamber, exposed to the gutta-percha orifices, it contaminates and reinfects the root canal problem and create a whole new problem, a new apical periodontitis, prevent the healing. The tooth becomes discolored, recurrent caries, and of course, the most important, the failure of endodontic treatment, restorative treatment, prosthodontic treatment. Over the past 2 decades, research in restorative dentistry and prosthodontics, dental materials, and endodontics has spotlighted coronal microleakage as a very important issue. It is unpreventable, but it can be controlled, especially in endodontics. I first noticed the problem back in the 70s at USC. Back then, our endodontic residents were requested to leave a post space in the endodontic completed cases and refer the patient back to the prosthodontic residents to do the cast, post, and core. That could be weeks or months later. We were surprised to see that our endodontic treatment were failing. Many cases failed. So we had to redo it again. Then we discovered because it's the idle post space. That post space, which we prepared for the prosthodontist, was a magnet for coronal microleakage. Excellent reservoir for bacteria to grow. Long distemperization periods of endodontic treaties were very detrimental. Therefore, we developed the concept and introduced the practice of building up the tooth with composites, with or without a post, as indicated. This is done as part or as continuum of the endodontic treatment. The guiding principle in this philosophy is that I want to safeguard, I want to protect the root canal we did from potential leakage, likewise protects the tooth from recurrent caries or fractures. And most important, I want to expedite the execution of the final restoration. I want to give a service to the GP, okay, to go ahead and do the crown preparation. The faster that's done, the better. The practice of waiting for symptoms to disappear and lesions to heal is not scientifically fortified or supported. It actually can cause harm. The delay causes harm. And it is, in my opinion, not a biological issue. It's a practice management issue. It's an insurance coverage issue. It's a question of money, availability to do the crown preparation and the restoration. But anyway, when that pulp chamber is exposed through the interim temporary, we are basically causing more coronal leakage, and we are basically causing potential failure of the endodontic treatment and everything else that follow. Thank you for listening.